Over to you, Martin.
Well, good evening, everybody, and welcome to our webinar on human toenail and what we can do with it. I'm joined tonight by Kirsty, who's our backdoor lady. She does all the marketing, all the technical stuff, all the stuff that I don't understand in the slightest. So if this all goes smoothly, it's down to Kirsty. If it all goes horribly wrong, it's down to Kirsty as well. And I'm also joined, of course, by Gaynor Wooldridge. For those of you who don't know, I'm currently the chair of the Institute of Chiropodists and Podiatrists, and Gaynor is currently the chair of the Medicines and Procedures Committee. However, she's not going to be that after Saturday, because my term of office comes to an end. So I will no longer be the chair of the executive, but Gaynor will. So things can probably get done properly now. And I'm just going to take a back seat and go and run the education department, which is something that I thoroughly enjoy anyway. And I've been wanting to try and do it for 4 years, but they wouldn't let me. So anyway, that's who you've got tonight speaking to you. Gaynor obviously is the true expert on nail reconstruction. I'm quite a Johnny-come-lately to this, but what I have found is it's an absolutely fascinating subject. As a podiatrist, often my first action is to consider nail surgery, but it's not always the best way to do things, because there can be reasons why nail surgery isn't suitable. There can be health issues, there can be access issues, there can be all sorts of things that mean if there are alternatives, then I think even as a confirmed nail surgeon, there are alternatives I think that are worth looking at. And of course, there are alternatives that can be provided by any appropriately trained person. You don't necessarily need to have a surgical qualification to do it. You don't necessarily have to be a podiatrist to do it. So what we're going to talk through tonight is I'm going to touch very, very briefly on nail pathologies and nail structures and so on and so forth. And then Gaynor is going to come in with the really interesting stuff, and she's going to talk about all the various non-surgical systems that you can use. And you can use, as I say, be you a podiatrist, be you a foot health practitioner. The training is available, which is something that Gaynor has been heavily involved in designing. And this is just really to give you a taste of what can be accomplished. So I'm sure that many of you will know the human nail as well as I do, although it is true to say that in our professions, even though we spend a lot of time looking at feet and looking at nails and cutting nails and taking them out and doing all the other things, it's still not perhaps as well understood as it should be. I became interested in the nails a couple of decades ago, really, when I first started doing nail surgery. And one of my mentors at the time was this chap. My screen should have advanced there, but it didn't. So let's try this. Right. Two consultant dermatologists, Dorber and his colleagues, who are consultant dermatologists at the Churchill Hospital in Oxford, and a statement that he made in his magnus opus, and I'll show you what I mean by his magnus opus. And this is that huge, enormous book, which is all on the subject of nails. Now, admittedly, about 20 years ago, that cost me the best part of 100 quid. It might be a little more expensive now, I don't know. But he made this statement that clinicians used to observing the slow rate of clearance of diseased or damaged nails are apt to view the nail apparatus as a rather inert structure. Oh, it's just a toenail. Whereas in point of fact, it's not just a toenail at all. It's quite a remarkable piece of the body. And as he says, it is in fact the center of marked kinetic and biochemical activity. And it certainly is. The more you study the nail, the more you realize that it is a fascinating structure. It's a window on the health of the body, because you can have changes of shape in the nails. They can come from interruptions in the growth, and the growth can be due to systemic disease, due to local disease, due to trauma, due to infections, fungal infections, which the nail is very, very apt at picking up. The nail color can change and various other things. The nail color and the nail structure can change if somebody, for example, is having chemotherapy for cancer. That can be a major cause of nail structure change, as can heart problems, heart attacks. I'll often see people who've had a myocardial infarction and they've lost their toenails, or their toenails have been damaged, sometimes turning into ingrown nails where the nail curves around. And sometimes there can seem to be no reason at all, but the nail just decides to go rogue. Now, that's a little photograph I took of the end of a nail. Not the healthiest nail in the world, but you can see there that the nail is actually quite clearly formed in three completely separate discrete layers. So you've got the dorsal layer on the top, you've got the intermediate layer in the middle of it, then you've got the ventral layer on the bottom. Now you can quite clearly see the dorsal layer on top. It's very, very thin, and you can quite clearly see the intermediate layer, which sits directly under it, which looks fairly smooth. And then you can see that rather crusty layer on the bottom, which is the ventral layer. Now that's not an entirely healthy bottom layer. In a normal nail, the bottom layer can be likened to dried glue. It keeps the nail down on the surface of the toe so that it doesn't flap around when you put your socks or your shoes on. That layer, the bottom layer, is slightly unhealthy. Now, it could be due to trauma, it could be due to fungus, it could be due to a number of things. I mean, I took this photograph quite a few years ago now, so I can't remember what was actually wrong with the person. But it does show that that nail has got quite a large incurvation around it. It looks like quite a deep rainbow there, whereas of course it should be much flatter than that. And it's a nail such as that may have been damaged by some factor which has damaged the bottom layer that actually makes the thing go rogue. And it can then mean that the sides of the nail become incised into the flesh. Now, as I say, there are surgical ways to correct that. But as I opened by saying, sometimes surgery isn't the best option. Sometimes it's an impossible option. Sometimes somebody will come from surgery and then you'll actually take the medical history and you'll think, well, you know, if I give you a local anesthetic, I'm probably going to kill you, or at least your leg is going to fall off. So there should be better ways of doing it. And it's the better ways of doing it that Gaynor is going to talk about in a minute. So what's a normal nail? Normal, what is normal? Well, normal-ish, I suppose. In a perfect world, a normal nail should have a uniform pinkish color. It shouldn't be excessively thick. It should be a nice smooth surface with minimal ridges or lines. It should not delaminate. Now, as I said in the previous slide, a normal nail is a laminated structure. In other words, it's got different laminae, it's got different layers. And in certain conditions of trauma, certain health conditions, etc., you can find that those layers become disjuncted from each other and they start to peel off. Sometimes the top layer will rip off and things like that. So a healthy nail should not. It should be a complete structure. And once again, our hypothetical normal nail should grow uniformly, consistent with the location. Now, obviously, the observant amongst you will see that that is a fingernail, whereas obviously we don't normally do fingernails in foot health and podiatry. But the reason why I found that was it's pretty hard very often to find a normal toenail. And when I was groping around for a picture of a normal toenail, all of the pictures that I've got, which obviously all the years I've been doing this, many hundreds, I couldn't find a nail that looked even remotely normal. And I didn't want to show you a diseased nail as an example of a normal nail, because whenever I come across something that looks rather nasty, snip, snip, you know, I get permission from the people and then snick, snick, I take a photograph of it. So I cheated and I used a picture of a fingernail. But in a perfect world, that's what a toenail should look like. Mine certainly don't look like that, I can assure you. Now, when we do anything to the nail in foot health or podiatry, really everything needs to be done on the basis of knowledge, because nasty things can be going on around the nail, not necessarily in the nail, for example, but the things that are going on around the nail can affect it. And you've got three conditions there that somebody might rock up to your surgery, or you might go and do them a home visit, and they might plonk one of those under your nose and expect you to cut it. Well, in an ideal world, you'll need to know everything that you're looking at there. I do sometimes show this set of slides to podiatry students, and I offer them a bottle of whiskey if they can get all three right. I can't remember the last time I got a bottle of whiskey, had to give a bottle of whiskey away. So things like this, not always well described in the literature, certainly not always well described in the training courses that we do, either in podiatry or in foot health. So you're looking at the top one, which you think, oh my God, that's probably gone horribly wrong. And it's actually something called Melanechia striata, which fortunately isn't something that's a problem. Well, certainly it's not a problem while it's presenting like that. And then you've got the one next to it on the top layer, which has got things called splinter hemorrhages in. Now, splinter hemorrhages are, as the name implies, it's a bleed under the nail, but it's a longitudinal bleed, essentially following the nail bed capillaries. That can be an indication of either nothing at all, just a bit of bad luck, or it can be an indication of various drugs and other medications affecting the nail, or it could be an indication of lung disease, it could be an indication of asbestosis, it could be an indication of a whole raft of things. So things that affect the whole body do affect the nail. And then, of course, the bottom one is what usually throws people. And that actually is something nasty. That is a malignant cancer under the nail. Malignant melanoma. Now, obviously, the nail itself, being basically a solid keratinized structure, hasn't got melanocytes, which are the pigment-producing cells that go rogue in malignant melanoma. So the nail itself can't become cancerous, but you can certainly have cancers forming under the nail, around the nail, by the side of the nail, and so on and so forth. And that one there, it actually resulted in the amputation of a toe. Then, unfortunately, that didn't get all of it. So it then resulted in the amputation of the foot. That was something that had been put down to be nail fungus by a GP, I hasten to add. And it had been treated for several months for nail fungus. And it was only when this person, in desperation, rocked up to a dermatology clinic that I was doing some work in at the time. And the dermatologist I was with, my friend Liz, she took one look at it and she said, it's a cancer, let's do a biopsy. Well, we actually did a biopsy of the toe. That came back, it had spread, so we took the toe off. That didn't quite get it, so we did further surgery and took off the foot. And all because really the person who should have been treating it didn't know what they were looking at and didn't treat it appropriately, which is another story that I won't go into great detail on. But I think what I'm trying to do here is to show that if you're going to do anything to the nail, it doesn't matter how complex or how simple, you need to have the underlying background knowledge in order to do it. There's another one. Now, I'm probably confident in saying that I don't think any of you would try to treat that as an ingrowing toenail. Unfortunately, once again, it came through a doctor's practice as an ingrowing toenail. And that, I mean, it's already been marked up for surgery. That was a malignant melanoma under the nail as well. So off it came, complete with the nail matrix, which is where the root is located, that actually joins itself to the distal phalanx, the distal bone of the toe. Unfortunately, we got all of it on that time. So the staging result came back from histology. Yeah, you got it. But once again, it brings it home. And if I'm trying to frighten you, then that's exactly what I am trying to do. I'm trying to make the point that nails are not simple. They're sometimes dismissed as being simple, dismissed as something, oh, you can learn about it on the internet and all the rest of it. No, I'm sorry, you need background information to do anything to the human nail. Certainly, as a professional, which all of us are. So, if you're going to do anything to the nail, I suggest to you that you need to know how the nail reacts to disease, to injury, to trauma, how it reacts to bending, because a lot of the correction systems that Gaynor will be talking about do involve bending the nail. If the sides are growing in, you want to try and straighten them and pull them out. So how does it react to that? How does the structure react to it? How does painting the nail cause it? Because there are paints that you just use to color the nail, of course, but there are other chemical paints that sometimes people put on the nail if they're trying to treat, for example, an imaginary nail fungus. And how do other chemicals react to the nails? I mean, certainly if you had Gaynor and myself talking about nails, then we'd bring up obscure things like plumber's disease. I won't wax lyrical about plumber's disease, but it's very interesting what it actually does to toenails and fingernails. Then, of course, if you're going to do things with nails, you need to know what happens if it all goes horribly wrong. And things can go horribly wrong from even the simplest procedure. This is somebody that actually rocked up to my hospital clinic having had an attempt at straightening the nail with a various system, and it was done in an imprecise and incorrect way. And that's the result. Bacterial paronychia, which is quite a severe infection of the tissue around the nail. So once again, it's not the nail that's infected. The nail is essentially inert. It's not strictly true, but essentially it is. But nonetheless, that's something that required swabbing, and it required me to prescribe quite a healthy dose of quite strong antibiotics. And of course, then, if somebody trying to do procedures on the nail does get it wrong, you then got dear old blind justice there holding the scales. Because there can always be a comeback, can't there? So I mean, this person, the first thing they said once they'd been cured was, "I'm going to sue that person who did that." I said, "Nothing to do with me, sorry." So it's probably a good idea, if you're going to get some training on nails, then choose your trainers wisely. I'm not saying that there are bad trainers out there. I'm not saying that there are good trainers out there. There are some I wouldn't go to, but equally there are some that I wouldn't hesitate to go to as well. So perhaps if one of your trainers lives in a shack like this, then it might be a good idea to run away from them. I certainly would. So I would suggest to you that there are some essentials you've got to consider. If you're going to start reconstructing nails in any way or fashion, first of all, get some professional training. And there is professional training around. And then once you've got the training, you decide you want to do some procedures, get some professional support. Now, obviously, I'm a member of the Institute of Chiropodists and Podiatrists, which has been hanging around since 1938. So we're not Johnny-come-latelys. And we do pride ourselves on professional training. So if any of you feel that you want to get some training on things to do with nails, it might be an idea to have a look at what the Institute does. And then, of course, the Institute, as the name suggests, is the Institute of Chiropodists and Podiatrists. So that is for chiropodists and podiatrists, because they're protected titles in law, as you know. You can only call yourself a chiropodist or podiatrist if you are on the HCPC register. But long ago, we recognized that people who perhaps didn't want to go the full route of degree qualification for podiatry, they still had substantial things, you know, where they can help, where they can do, where they can provide essential services. It's probably true to say now that there's a number of podiatrists, and also we see this in the NHS as well, a number of NHS clinics that could not continue to operate without having foot health practitioner support, without having podiatry assistant support, and so on and so forth, because there just aren't enough podiatrists to go around. And in the same way that you know, dentists need dental hygienists to make sure that they can continue to work, we need foot health practitioners. So that's why the Institute several years ago started its own College of Foot Health for members of the who wanted to become, you know, trained as foot health practitioners, foot health professionals, podiatry assistants, but needed their own support organization. And that's where you come across a reference to the College of Foot Health. That's actually owned in total by the Institute of Chiropodists and Podiatrists. So it does a lot of training for foot health professionals, and hopefully it's professional training for foot health professionals, which is what that's just really to repeat what I've said there. It's a training and a support organizations wholly owned by the Institute. The Institute itself is a for-profit professional podiatry body. We're recognised by the Department of Health, Education England, the UK Health Professions Council. Any tutor who works for the Institute are all podiatrists. They're all degree qualified podiatrists, and they all have an adult teaching qualification. So if you come to any learning event that's been put on by the Institute, you'll find that it's got some good backbone to it. So I've waxed lyrical. Perhaps I'm sorry if I've bored you a little bit, but I think it's necessary to know the background to some of the things we're going to talk about. So I think that exhausts me. You'll probably be glad to hear I can have a nice cup of tea. Cheers. And while I listen to Gaynor telling us everything about nail reconstruction, bracing, and all these other fantastic things that we're going to learn.
Martin, thank you very much. And thank you everybody for being here this evening as well. It's great to, I wish I could see you all, I can't, but it's nice to know that you're all there. I'm not certain if Kirsty, yes, she has, thank you. Thank you, Kirsty, for sorting that out. Well, following Martin's talk, it is really important to know the background to what we're actually going to be putting on the nail. So I think that's a really useful adjunct for the nail bracing. We are going to talk about bracing and correction systems tonight, and basically introduce the very, very underused nail brace, and looking at what an absolutely amazing treatment it is. So many great options out there with nail bracing for our patients. So what is the theory behind the nail brace? Well, the nail plate, as Martin's already said, begins its life as cells produced actually at the matrix. These cells are generated from the nail plate as it grows. Unfortunately, if you have a nail bed that's too small for the nail plate, or you've got trauma, that's pressure from the shoe, the loading of the toe box, the nail can start to curve very, very easily. And it actually follows a law called Davis's law, which actually means physiologically it heals in the model of mechanical stress that's applied. So if you've got a toe box that's too tight on the nail plate, it will actually continue to grow like that, and it will remain like that. So when a nail brace is applied, it puts the nail growth back on track from the matrix, so it actually straightens that nail as it's actually growing out. If we actually move on, Kirsty, and have a look what a nail brace is. Actually, nail braces have been around for quite a long time. They were actually developed, as we see there, in 1872, but it wasn't for a long time until the 1960s that actually became very, very widely used in Europe and the US and Australia. For some reason, we just haven't embraced nail braces. I don't know why. It's a very sensible option. I think these days it's becoming more and more of an option when we look at all of the people who actually avoid nail surgery, because that's really the option, conservative treatment on nail surgery. And I think about 60% of people actually don't present in clinic at all because they're so worried about actually having treatment, or they're needle phobic. Braces actually come in a wide variety of materials, including wire, resins, composite resins, fiberglass, plastic, or a mixture of a couple of those together. They are conservative, they're very safe, it's a very safe method of treatment, and with right patient selection, which is something that is really, really important. So not only just looking at nail pathologies that are presenting, but actually the patient as they're actually coming into clinic. So right patient selection is really important. Some people suffering with ingrown toenails actually do slip through the net. So many of them do. They end up with just trying to treat at home, where then they come into clinic. By the time they do come into clinic, or you have a domiciliary visit with them, they've got terrible, constant, chronic, infected, hypergranulated tissue, and it's almost impossible to do anything apart from actually sort of send them for nail surgery, which is a pretty aggressive treatment as well. And it can have downsides too. Sometimes it's not successful. Sometimes it becomes infected, and actually very, very hard then to treat, and possibly more invasive treatments following a nail surgery that hasn't gone very successfully. And it's also a less aggressive option for patients as well as clinicians. So it's actually quite nice as a nice option. It doesn't require anaesthetic. There's no recovery period. And it can be used for a long period of time, very, very successfully and safely. Okay, so who is it actually suitable for? Well, I will say everybody, but that's probably not quite true, because if you get the nail that we'll have a look coming up in a slide a couple away, that person unfortunately left it so long, I couldn't actually put a nail brace on. But we can have a look at children, people who are anxious, needle phobic people. So many people are really worried about coming into surgery. They'll put everything, they'll just put it off because they're just so worried about actually having any treatment at all, or a painful toe. They don't want anyone to actually touch the toe. People with diabetes, type 2 diabetes, PVD and poor healing, autoimmune problems, and very high risk people. And it really is a fantastic starting point for many. So if we have a look, this is the person I was talking about. He actually had a problem for about 10 years plus, unfortunately. He was actually practically dragged to the clinic by his girlfriend, and it was too late, unfortunately. He was distraught, actually, sitting in a chair. He had a terrible fear of needles, and he didn't want surgery at all. He did actually have to have surgery. If we have a look at patient selection, if this person had actually not been so worried, if we'd have had options to treat that person before, and he knew about those options, we could have had a look at and hopefully treated that many years before, and he'd have avoided all of this awful 10-year plus period of time of bleeding, infection. So during our training, if you do decide to come on the training, which would be lovely to see some of you there, we will look at nail pathologies and the patient selection. So hopefully we can confidently decide who will benefit and who possibly will need something more. So, you know, nail surgery is an option for some, and sometimes it is the only option. And I'm certain Martin sees a lot of those people as well at that end of the scale where actually there isn't an option. So nail bracing wouldn't be the option for them. Okay, let's have a look at the next slide. This patient, nail braces, it works really well if you've removed a toenail or somebody has come to you with a removed toenail that's been removed for fungal infection particularly, or as a regrowth after an ingrown toenail and hasn't been venalized. This person actually came into clinic with a really nasty fungal infection, and we tried a couple of different methods. They'd already tried oral terbinafine, and we decided to take the nail plate off and start again. So after that had been healed, she treated with Lamisil spray. The nail repaired itself. So if we have a move on, Kirsty, for the next slide, the nail was fantastic. The terbinafine, the Lamisil spray worked really well. So it started growing excellently, not a sign of the fungal infection, but unfortunately, it became quite curved, formed a granuloma at the very, very top of that, the apex of the toe, which meant the nail was blocked. It actually couldn't really grow past the granuloma. It removed the granuloma, but she was having quite an ingrown toenail after that because the nail was quite flat. After the removal, no fungal infection, the nail actually flattened out pretty extensively. So she then had sides of the nail that were actually growing in. So we used a nail brace back in December and treated a couple of times with a couple of different nail braces. If you want to go to the next slide, Kirsty, because this is actually how it was today. We actually put another nail brace on today just to try and get those very, very last edges past the distal edge of that toe. But she's really happy. I'm really happy. It was a really good result. So no problems at all, no pain. It was a very, very good result with the nail brace. If we have a look at this next slide. So this obviously is something that we see a lot of, chronically inflamed, infected, horrible. So ordinarily, I suppose at this stage, probably you might be tempted to do a nail surgery on this or send it to somebody who would prefer to do nail surgery. this nail actually had an application of a Podofix, which in the nail training we'll be having a look at the Podofix, which is a combination of a plastic and a wire brace. You can see it, sorry, I'm pointing to it, but you can't see me pointing. So that was applied sort of fairly near to the matrix there. And the nail plate was growing up, obviously pretty infected. Some gauze slipped under the nail just to slightly elevate that while that nail is growing from the matrix and being flattened. Slight traction on that nail plate to flatten that nail plate as it's growing from the matrix. Okay, if we just move on to that next slide. So we can see now that the nail is pretty clear, actually. It's a little bit inflamed still, but that Podofix brace is now almost halfway up the nail, doing really well. There's then the Combi Ped, which is a metal brace, and it's a combination metal again and a little plastic pad there that's attached. So hooking onto the nail plate and attached with a glue. So that was put again as a second brace, as more of a traction, because it actually applies more traction on both sides of that nail. So as it's growing through from the matrix, that's applying traction too. Podofix was taken off on that next slide, and the Combi Ped brace has been left on. You can see the hook underneath that nail plate, but it's actually looking really good. So if we then look at the next slide, and that's the very, very initial start of the bracing to the outcome, which was resolved after 8 months of brace therapy. So pretty good. So it's a pretty wide nail. It's quite fan-shaped, but I think that's a really good outcome. So if we have a look, in the training that we'll be doing in July, for anybody who is interested in hopefully coming on the training course, these are the braces that we'll be having a look at. Practically, we'll be talking about the theory behind them a little bit more, and also we'll be looking and practically trying them. So everybody will be trying all of these braces. They are all a little bit different. So we've got to mix those, the BS Spange there, a variety of fiberglass braces, and the Podofix and the Combi Ped. And I'm hoping actually that we can have the Podo Stripe that will be coming as well from Germany. So there'll be another 3. So the Podofix and the Combi Ped are a little bit of a combination of a wire and a plastic. And the Podo Stripe is more of a flexible plastic that acts a little bit like an elastic band. It is glued to the nail plate, but it acts like a little bit of an elastic band. So that gives traction slightly less than a Podofix and a Combi Ped. So all of those systems hopefully will meet the needs of most of the patients that you will actually will arrive in your clinic. And if we just move on to the next slides, these just are a little bit about the systems. The classic, using glue, it's fiberglass brace there. Literally, it's applied straight to the nail plate. Pretty simple, as is the next slide, which is the Spange Quick. Much the same fiberglass brace, but you can apply without, you can actually see that it actually peels off, and you just literally apply that with a glue too, but you don't need to have equipment to actually sort of stick it. You can just literally stick it with your, push it down with your finger, hold it in place, and they last normally between about sort of 5-6 weeks. Presumably, most people would want to get somebody in between that sort of 4 to 6 week period of time. I always get people in. I like to see what's happening with the nail plate. If there's any problem, patients can always contact you. Sometimes, if the nail hasn't been prepared properly, sometimes that the brace can detach itself. With the metal braces, the hook under, sometimes there is a problem because most of the time you're using those sort of bracing systems for a more complex problem, more thickened nail, and potentially a more inflamed and infected nail. So you'd want to keep a check on these people and these patients through that progress. You sometimes apply more than one brace, so that the first brace might be sort of a third of the way up. You might put another brace underneath that, or you might take the first brace off and just put a reapplication of another brace on as it's going through to actually control the matrix. So the next one with the magnetic, again, part of the BS Spange range. So there's a number of different bracing systems that are fiberglass, but a different way of applying those braces. So they are much the same, but different ways. And it's nice to handle all of them because you get a feel for, for what you feel comfortable with. So it's nice to have a broad range of all of these different braces, and actually a couple of different selections in clinic for different types of patients that you will actually be, looking at and working with. The next two are the Podofix and the CombiPed on the next slide. Again, the first one, the Podofix, is a combination of the wire and the plastic. The plastic part is sort of bent, you physically bend just to sort of to mimic the shape of the patient's toenail that you're actually working with. So there's not going to be too much traction. So that brace is applied with the glue, and there's a little device that you twist and tuck in the wire just to apply the traction that you feel is appropriate for that patient. And the CombiPed, the last one, which is a little bit like the 3TO brace, which I know that we have been discussing a little bit with the 3TO. These are both 3TO, part of the 3TO brace systems, but there is another brace that's actually wire on both sides of the nail and a connector in the middle. But this one, the CombiPed, works really well with the thicker, the very involute, the really problematic nails. So that's a more heavy duty one. So we'll be working with all of those just to get a feel for all of those. Excellent. So if we have a look, return on the investment, obviously we all work in the foot health field, and it's really important to work and provide the best possible care and support for our patients. Primarily, that's absolutely my aim, and I'm certain that that's the aim for most people here, and achieve the best outcome. Obviously, it is our profession and it's our income, so it's what we do. We need to earn a living too. No surgery will always be there for some patients, but no bracing is actually, it can offer a safe, effective and affordable treatment for patients, but it's also an extremely effective revenue stream for your business. It really is. If you look at some of the costings here, the quick and the classic from Canonbury mark the costs of those. So if you look at 60 braces on the classic, which is £218, the braces actually cost about £3 to £4 each to fit. So you could, it's not rocket science to work out, actually. You probably made the cost of that system within about 9 or 10 treatments, actually. So if you charge about £25, that's a rough, certainly from my point of view, when I have patients coming in, normally I charge £25 plus the treatment fee for each time they come in for treatment on the brace. So it doesn't take a long time to actually make your money back on the brace systems, and that's all of them. The classic definitely has probably the largest amount in the pack, but then it's more expensive. The quick, I think I said 39, but I think it's actually got 30, it's got 30 braces in the quick brace system, but it's 167.70. So the money is made back fairly quickly, and it's an extremely safe, excellent. And I can't tell you, it seems really strange that we haven't embraced braces in the UK, and we haven't. I don't know why. They're incredibly popular in Europe, and they work really effectively. So we'll discuss this in greater depth as well on the training if you decide to come with us and do some training. But it's an excellent investment. This week alone, I have probably put about 12 braces on patients. So it's just Wednesday. To me, it's a no-brainer because it's something that it's not a painful procedure at all. Obviously, if you have an ingrown nail that's uncomfortable, you need to make certain it's not uncomfortable before you put the brace on. But actually, it's such an excellent way forward for your patients. It's lovely. It's really nice to actually see them come back and have such a great result as well in a short space of time, because it can take somebody in pain out of pain really pretty quickly. So if we just look at the last slide, it is a vision for future practice for all of us. We have a non-surgical, non-invasive option for so many people who would have slipped through the net for many reasons, so many reasons. I think it's an exciting time for our profession to be working in private practice. The more options we have, the better to offer our patients. Safe and non-painful, non-aggressive treatment should always be the best option, initial option anyway, if appropriate. And nail brace systems provide all of this and much more. So thank you for listening, and it will be really fantastic to see some of you at the nail bracing course in July.